So in this video on the thyroid, we're going to look at more of the thyroid physiology. We're going to explore the different thyroid hormones. I'll talk about the thyroid hormone synthesis and release, the role of iodine, how much iodine is necessary, and so forth, about iodine supplementation. Talk about thyroid hormone regulation through the so-called HPT axis, that's hypothalamus pituitary thyroid axis. Role of TSH, thyroid hormone transport, the Diodinases, which convert the T4 to the active T3 within cells, and then thyroid hormone receptors. So the thyroid gland technically produces 5 different iodine-containing hormones. They're all derived from tyrosine, but only 2 are the ones we really think about clinically as the most significant. So this kind of gives you the molecular sort of arrangements of these. So here's tyrosine. Remember that tyrosine is an amino acid. It has an aromatic ring, which is hydroxylated on the outside there. And thyroxine, T4, is basically you take the tyrosine structure, attach another aromatic ring, and then you attach 4 iodines to those aromatic rings. T3, triiodothyronine is its technical name, is basically the same molecule that's been deiodinated in that outer position. And then there's another molecule we'll talk about called reverse T3. When thyroid is now going to be inactivated, the Diodinases can convert the T4, T3 into reverse T3. And this is basically the same molecule, but now the iodine is removed from the inner ring and not the outer ring. This particular molecule, reverse T3, cannot bind to the thyroid receptor, and so we consider it to be metabolically inactive. It's kind of the disposal form of thyroid. And we'll talk a lot about reverse T3 because that's in more functional medicine circles, that's being measured as sort of a marker of chronic stress and whatnot in the body. It's really not a good practice to do that, and we'll talk about some of the controversy around that. So T4 or LT4, levothyroxine, it goes by, it actually has different, it's a thyroid replacement therapy, so it goes by the name of Synthroid, etc. That is about 90%, 85% or so of the whole thyroid gland secretion. Again, it contains 4 iodine atoms, and the thyroid, so this is the primary form of thyroid that the gland itself secretes. But it is inactive because it, in and of itself, can't bind to the thyroid receptors. The T4 levels reach significant levels, again, around 18 to 20 weeks gestation. And it has about a 7-day half-life. That's very long. So it stays in the system. It's going to be absorbed into cells. There's actually a transporter that brings it into cells. And then once in the cell, it's going to be converted into T3, triiodothyronine. In terms of the replacement therapy, that goes by the name of Cytomel or liothyronine. That's about 9% of the gland secretion, contains the 3 iodine atoms that we just talked about. And the T3 levels don't really start picking up until around 30 weeks gestation in the fetus. And the plasma half-life of this one is only a day. So this is more of a cellular level activity, and we don't see it stay around in the blood as much. Again, the enzymes that convert T4 to T3 are the Diodinases, and there are actually 3 types, D1, D2, or Di1, Di2, Di3. Di2 is going to be the one that's most important for the peripheral conversion of T4 to T3. And so T3 can actually bind to thyroid receptors, so we say this is the active form of thyroid. Reverse T3, again, it's been deiodinated in the inner ring, not the outer ring. The thyroid gland actually does secrete a little reverse T3, about 0.9%, but it's mostly what we measure in the blood has been produced in tissues from T4 via the action of type 3 deiodinase. So it's the type 3 that converts T4 into reverse T3. It also breaks down T3. So basically this is our disposal form when we want to inactivate thyroid, is reverse T3. The levels increase there's a condition known as euthyroid 6 syndrome, or non-thyroidal illness syndrome, NTIS. And you see that in critical care patients, like in the ICU and whatnot. And that's probably because the body is going into sort of a conservation mode metabolically. So the thyroid hormones are being downregulated. and in particular, the reverse T3 levels go up. So people will have symptoms of hypothyroidism, and what we now know, interestingly, is if you supplement them with thyroid, they actually don't get better, and the outcomes aren't better. So that's in a more critical care kind of setting. A lot of naturopaths or functional medicine doctors and whatnot are now recommending that we measure reverse T3 as a marker of basically cortisol levels. So as cortisol levels go up, the levels of DI3, the activity actually increases. So the idea there is that hypercortisolism can result in more reverse T3, and then you get low thyroid. And while I think there's a lot of data suggesting that's correct from different angles, measuring reverse T3 is not necessarily a good measure of that. One of the problems is reverse T3 has a very short half-life of, I think it's 20-30 minutes. It's going to fluctuate wildly throughout the day. And so it can't really be used as an accurate measure of what's happening inside the cell. So most of the guideline committees around thyroid are now saying don't measure reverse T3 and that it doesn't really give you any meaningful clinical data. That's going to be controversial, I think, in the more functional medicine circles where they still recommend that. I think there is some interesting ratios looking at T3 to reverse T3 ratio, and that might actually be a more accurate marker of how much active thyroid is available to the cells. So there's some literature looking at that. The thyroid also, in the process of making T4 and T3, produces what's called T2, and that is a form of tyrosine that's iodinated but only has 2 iodine groups attached to it. That's called DIT. It's only produced in small amounts. It's considered inactive. We don't measure it in the blood tests clinically, but there's some data suggesting it actually can further stimulate mitochondria. So I've seen a little bit of a peripheral literature around this looking at DI2 supplementation. There currently are no prescription medications that do that, but maybe there's some role for general metabolism. And then there's a T1 or MIT that has a single iodine attached to tyrosine. Again, we don't have much data that it has any active physiologic role. And then I mentioned the calcitonin already, that's secreted by the C cells, the parafollicular cells, and that's going to pose the effects of parathyroid hormone and can serve as a marker for medullary thyroid cancer. So that's pretty much it in terms of the major hormones secreted by the thyroid gland. Now I mentioned that thyroid globulin is the main storage form of thyroid hormones inside the colloid, and it's basically a large iodinated protein composed of lots of tyrosine. So remember, proteins are basically just amino acids all stuck together via peptide bonds. We'll put a lot of tyrosine in there. With a couple of other amino acids, we get thyroid globulin. And it's originally synthesized in the rough endoplasmic reticulum of the follicular cells. So follicular cells make it, they attach the iodine. Actually, the iodine will be attached in the colloid space, but the protein itself is synthesized within the rough endoplasmic reticulum. So I think we have that picture here. So here is the endoplasmic reticulum up here outside the nucleus, and the thyroid globulin is packaged into that, and then via exocytosis it leaves the follicular cell and it enters the colloid. On this side of the follicular cell to the right here, you can see the blood, and here's the sodium iodide symporter, which is bringing the iodide ions in. And then the iodide ions are going to go through the follicular cell. There's a channel called the pendrin, and that's going to allow the iodide ion to go into the colloid, where it then undergoes oxidation via an enzyme called thyroid peroxidase, TPO. It's actually found technically on the surface here of the follicular cell. And the TPO will oxidize the iodine, I negative ion, into molecular iodine. That will actually, or just iodine, non-ion, just the atom of iodine. And that will then attach itself to the thyroid globulin via a process called iodination. And then, so then we have these iodinated tyrosine residues that are part of that thyroid globulin. When it's time to make thyroid hormone, and that would be TSH, not shown in this picture, coming in through the capillary, it's going to bind to the TSH receptor on the follicular cell, And that'll induce a whole series of intercellular signals, which will then cause the thyroglobulin to be endocytosed into the follicular cell. It undergoes a process of proteolysis into thyroxine, the T4, triiodothyronine, T2, and then a little bit of MIT and DIT and so forth. And then that is removed via channel into the blood. So that, in a nutshell, is the whole process of thyroid hormone synthesis. Again, this is happening inside the follicle, and this little picture here is really a blow-up of one of those follicular cells and its activities. Okay, so I think I just pretty much covered everything that's written here already. Again, the importance here is thyroid peroxidase. That is another protein. It's, of course, a protein. It's an enzyme, and it's a target of the immune system in autoimmune thyroid disease. So like Hashimoto's, autoimmune thyroiditis, we get antibodies against TPO as well as thyroglobulin, and they serve as useful clinical markers for actually confirming there's autoimmune thyroid disease. Certain drugs can also block TPO, and they can be used in hyperthyroidism. So that would be propylthiouracil, PTU, and a drug called carbimazole, which is converted to methimazole. In fact, we just use basically methimazole as the medication. Also goes by the name of Tapazole. But methimazole can inhibit TPO, and that inhibits further thyroid production. So that could be useful in hyperthyroidism. We'll talk about that when we look at hyperthyroidism and its treatments. Again, to release the hormones, we need TSH binding to the TSH receptors, and that's going to initiate the whole process I just talked about. And then in the peripheral tissues, the T4 via Diodinases will be converted to T3. Now, TSH has other roles than just getting thyroid hormone out of the follicular cells. It also increases synthesis of more thyroglobulin. It also increases the blood flow and the vascularity to the thyroid gland, and it causes follicular cell hypertrophy. So, and that can lead to gland enlargement, and we call that a goiter. Lots of different causes of goiter, but one could be from excess TSH stimulation. And so this can happen in autoimmune hypothyroidism, again known as, it's called Hashimoto's thyroiditis. Autoimmune hypothyroidism, we get an elevation of TSH. The brain continues because it perceives low thyroid hormones in the blood. What's happening is the thyroid gland is being destroyed by the immune system. So the levels of T4, T3 drop, but the brain, perceiving that, puts out more TSH to try to stimulate the thyroid gland. So TSH levels go up, they rise. So we get an increased TSH in Hashimoto's, and decreased, levels of T4 in the blood. And as a result of that increased TSH, this can cause goiter, because basically the gland's not putting out, but the brain keeps putting that in there, and the TSH has all these other pro-growth proliferative effects in the body. And not just the body, but primarily on the thyroid. So the thyroid can overgrow with too much TSH. Now, calcitonin production, I just want to say a little bit about that. That's going to be secreted in response to elevated serum calcium. So when the calcium levels go up, calcitonin is released. And then as calcium levels fall, parathyroid hormones released. So this is going to maintain your blood homeostasis on the blood calcium levels. This is why just taking, just one example of how just taking mineral supplements isn't going to affect, if your hormones are balanced and healthy, and actively working to maintain homeostasis, is not going to affect the levels of the plasma amounts of those electrolytes. So if you have hypocalcemia, just taking extra calcium is not necessarily going to be the solution to that. In fact, that often indicates a deeper endocrinopathy that has to be looked at. So we'll talk all about hypocalcemia and hypercalcemia with the parathyroids, but this is one example of how we maintain homeostasis on these different electrolytes. Usually the calcium metabolism remains clinically normal after removal of the thyroid gland, and that is called a thyroidectomy. But if you were to remove the parathyroid glands, you're going to have severe effects on calcium metabolism, and that's why we don't think calcitonin has as much of a physiologic role as parathyroid hormone. One of the effects that we know calcitonin does to basically remove calcium from the blood is to increase the activity of osteoblasts. So osteoblasts are the cells in the bone that make new bone, and the osteoclasts are the cells that break the bone down. So calcitonin decreases osteoclast activity, most likely upregulates osteoblasts, and that's what gets the calcium more fixed into the bone. So that's a little bit on calcitonin production and secretion. So I want to say a little bit more about iodine. So iodine in nature, in foods, is found usually as iodide ion or as iodate, IO3. When we eat these iodine-rich foods, then we basically have iodide ion that enters circulation, and that's what circulates around, and that's what we showed is taken up, for example, by that sodium iodide symporter in the thyroid gland. There are other symporters in tissues like the gastric mucosa, in the breast, salivary glands, in the skin itself, in the cerebral spinal fluid, oral mucosa, pancreas, and thymus. Again, we can think this is because iodine has a very strong antimicrobial role, and so this could be part of the innate immune defenses of those organs. The thyroid stores up to 8 to 10 milligrams of iodine in the form of the iodinated tyrosines and the thyroglobulin and the thyroid hormones. And iodine is then excreted by the kidneys, and so we can actually use the urine iodide excretion as an index for dietary intake. So because it's almost entirely excreted by the kidneys, we can get a really accurate estimate of dietary intake based on the urine levels of iodine. So that's probably the most accurate test. There are other tests where you use a skin test. You, like, for example, smear iodine on the skin, and depending on how quickly the body absorbs that, people can get a basic idea of your iodine status. I don't think that's particularly sensitive, so really, if we're going to measure iodine, we usually estimate it based on the person's dietary intake, but if you wanted to measure it, the urine iodide excretion is the best test. The WHO has defined a daily dietary iodine intake of adequate of being 150 micrograms for adults or 200 micrograms for pregnant or lactating women, and anywhere between 50 and 250 micrograms for children. That's basically about 1 kelp tablet. If you eat a cup of miso soup with some seaweed a day and that's adequate. But where most people in the US actually get their iodine is actually from iodized salt. So they put now iodine in the salt, and people through any sort of processed foods or salted foods usually get their iodine from that. Interesting, if you buy the natural sea salts and whatnot, they're usually not fortified with iodine, and if you're not taking iodine in from other food sources, you could potentially, that could result in deficiency, and this is a major problem worldwide. In the US, the median intake for the year 2000 at least was for men between 240 and 300 micrograms a day, and in females about 190 to 210 micrograms per day. And again, that's usually from processed foods. In Japan, the median intake is around 1 to 3 milligrams per day. That's 1,000 to 3,000 micrograms. So they get a lot larger amounts of iodine. Now, some people argue that's very protective, and we actually have people recommending, physicians recommending that patients take very high concentrations of iodine. As we'll see, there's some potential negative consequences to that. So what we're finding with iodine, like most other nutrients, is an inverted J-shaped curve, where if this is 0 intake, and this is a positive effect on thyroid physiology, and here's a negative effect, we see deficiency usually has a negative effect. Then you start supplementing, so going to the right on dosage here. You start supplementing, you see a beneficial effect, but then it quickly falls off again, and we start seeing the opposite effect. So this is a classic hormesis curve that we're seeing pretty much with every nutrient at this point, including vitamins. And so there is a ideal spot for iodine, but that generally is somewhere between 150 and maybe 250 micrograms per day. So that's not a very large amount. The body actually conserves iodine very well. In terms of iodine deficiency, this actually affects a very large portion of the global population. That's about 2 billion people, about a third of the total world population currently. And that's an intake of less than 100 micrograms per day. An intake of less than 50 micrograms per day, the gland can't maintain thyroid hormone production, and we start to see enlargement, and that is a cause of goiter and hypothyroidism. Now, iodine deficiency is the #1 cause of hypothyroidism worldwide. In the United States, it's actually pretty rare because of the fortified foods and the iodized salt. Most people in the United States actually get hypothyroidism from autoimmune disease, and that's again Hashimoto's. So that's an important distinction because iodine supplementation in Hashimoto's actually is often contraindicated. It can actually result in thyroid toxicosis or excess thyroid secretion in some patients, or maybe even suppress their thyroid further if the level is too high. Here's a picture of a very large goiter. There are many areas in Africa, in different parts of Asia, north of India and whatnot, even into China, where the soil is very poor in iodine. People are not eating a lot of seafood in these areas, and so the food they're eating is actually iodine depleted, and so they get severe iodine deficiency and goiter. This is a massive goiter here. So our major sources are from seafood, if you don't have the fortification through the salt. So fish, shellfish, kelp. Dairy products are fairly rich in iodine: milk, cheese, eggs. Again, the iodized salts. Lugol's solution is potassium iodide in water. And then there is supersaturated potassium iodide, SSKI. Iodine 131. So iodine has a number of different isotopes. Iodine 131 has a half-life of about 8 days. It's actually a component of nuclear fallout. And being iodine, of course the body can't distinguish isotopes, it just concentrates the chemical element. Will concentrate in the thyroid, and iodine 131 concentrated there, it's going to emit radiation, and that's going to potentially induce thyroid cancer. So one of the treatments for radiation exposure of iodine fallout is to take supersaturated potassium iodide, and that basically saturates your body with non-radioactive iodine, and that will replace any radioactive iodine that's made its way into your thyroid. So that's why we saw with like the Fukushima nuclear meltdown, the global sales of potassium iodide skyrocketed. In fact, a lot of internet sources ran out of potassium iodide. People were buying this up. The thing about this again is the half-life's about 8 days, so it's very short. If you look at Fukushima, many of the isotopes I believe were cesium and other isotopes, and they have half-lives of like 10 to 30,000 years. And those are the ones we're really concerned about bioaccumulating over time. The iodine 131 is also used as a treatment for thyroid cancer and hyperthyroidism in particular. So one of the treatments available for hyperthyroidism, and again in the United States the primary cause of hyperthyroidism is autoimmune, and that's called Graves' disease. And we'll talk about that. That's actually going back to the thyroid hormone receptor. That's where the body makes antibodies against the TSH receptor in the follicular cells, but instead of blocking them, the antibodies stimulate the TSH receptor, and so that's called a thyroid stimulating antibody, a TSI. So we make these stimulating antibodies, and that basically causes your thyroid to oversecrete. So one of the treatments is, we talked already about the methimazole and the propylthiouracil, they block TPO. Another treatment is to use radioactive iodine, give a high dose. It basically destroys the thyroid, and then a person will have to take thyroid supplements after that to maintain their thyroid levels. So that's a way of sort of doing a radioactive thyroidectomy. We'll talk about that as a treatment potential option for hyperthyroidism. There's another isotope, iodine 123, and that's used for thyroid diagnostic imaging. I should mention there are actually 37 isotopes of iodine. All of them undergo radioactive decay except for iodine 127. So iodine 127 is the stable form of iodine. So we usually talk about just, iodine in the diet and whatnot. It's usually 127. These others will form, for example, in nuclear reactors, as part of natural radioactive activity and so forth. Now, iodine is a halogen, and halogens in the periodic table other halogens would include bromine and fluorine and so forth, and chlorine. These halogens all have, of course, one negative charge if they have 7 electrons in their outer orbit. They basically can gain another electron, become negatively charged. So, like iodine, again, normally exists as the iodide ion. But the same thing with fluorine and bromine and so forth. So these are very electron hungry, and they can also substitute for one another in chemical reactions because the chemistry is the same. So we can start replacing, unfortunately, iodine in the thyroid with other halogens, and in particular fluorine, which of course we now fluoridate the water in many cities. One concern is that that can concentrate in the thyroid gland and over time inhibit thyroid production. And so people might need to take a little extra iodine to be sure the fluorine doesn't outcompete it. Chlorine also, from like swimming pools and whatnot, if you're getting a lot of chlorinated products, there is what's called perchlorate, which is an ingredient in rocket fuel. But unfortunately, that is now, because of all the rocket launches and whatnot, that now has disseminated into the atmosphere all over the world, and that's contaminated food everywhere as well. Bromine is used in baked goods and plastics and so forth. That also, in bromated medications, that also can replace iodine. One other interesting medication is Prozac. Fluoxetine, it is fluoridated, so that actually contains fluorine, and there's some concern that that in particular could potentially inhibit thyroid over time. Whether or not that molecule itself could be incorporated if it's maybe too large, but that could actually have an effect on the thyroid globulin production. So those are the sources of iodine, the different isotopes, and then the halogens and how it might replace iodine in the thyroid gland. Of course, you need iodine to make proper thyroid hormone within that limit set by the WHO. We also see iodine deficiency, in addition to hypothyroidism worldwide, contributes to fibrocystic breasts and potentially breast cancer. So I mentioned that the breast actively concentrates iodine. A lot of that enters the breast milk for the baby for its own thyroid production, but also potentially as an antimicrobial substance. And so you see the breast actually develop into almost like a goiter-like hyperplasia when the iodine levels are low. So that's something to think about with fibrocystic breasts, is iodine status. And there's some evidence connecting stomach cancer as well with iodine deficiency. And so that's another potential role there. There's this question mark here with autism in terms of iodine deficiency, and that's probably through the thyroid effects. We do find there's increased hypothyroidism often in autistic children, and so it could be due to low iodine in some cases. Now, a couple of health risks from iodine should mention. There's something called the Jod base-down phenomena, and that is basically hyperthyroidism from excess iodine ingestion. I've had a couple of patients who thought it would be a good idea to take 1 to 2 milligrams of iodine, kind of to support their thyroid, and they actually develop hyperthyroidism. And this typically occurs not in normal patients with normal thyroids, but patients who already have a predisposition to Graves or goiter. So there's some underlying thyroid pathology already. The opposite effect would be the Wolff-Chaikoff effect, and that is hypothyroidism from excess iodine ingestion in really large amounts. So typically with the high doses, iodine can actually inhibit the organification, and that's the attachment of the iodine to the thyroid globulin. So patients with Graves are more susceptible than euthyroid. Euthyroid just means normal thyroid production. But it can occur in both. So Wolff-Chaikoff is often actually used in a positive sense before, let's say, a thyroid surgery. Iodine is given in large amounts to kind of downregulate the thyroid gland. That effect lasts for about 10 days. So that's something to think about for patients who maybe on their own, maybe self-medicate with iodine. They can actually potentially either upregulate or downregulate their gland depending on their pathologies and the amount they take. So that's a little there on iodine. Now, the secretion of thyroid hormone from the gland is regulated by the hypothalamus and pituitary, and that's the so-called HPT axis. So in the hypothalamus, there are basically ways the hypothalamus can detect your levels of thyroid hormone. In particular, it's sensing the levels of T4 in the blood. Then the T4 enters the hypothalamus, it's converted to T3, and then depending on the T3 levels, if it's low, the hypothalamus will then release TRH in response, and that will actually travel down a little portal blood system down the infundibulum of the anterior pituitary, and will stimulate thyrotrophic cells to release TSH from the anterior pituitary. That'll enter circulation, and then in the thyroid, we already showed that binds to the follicular cells, and that will release thyroid hormone. The half-life of TSH is about 1 hour, but it's considered to be an extremely accurate measure of your thyroid plasma levels. There's a negative feedback that occurs, so as the T4 levels go up in the blood, then they feed back in a negative way in the hypothalamus, which downregulates TSH and so forth. The T4, T3 also has a direct role of downregulating the cells in the anterior pituitary. So there's a second little pathway there, but we usually think of it from the hypothalamic level. Then the T4, T3, once it's carried around the body, then eventually it's going to be disposed of. It's going to be, and the cells converted to reverse T3. The liver also converts some amount of T4 to T3. In fact, this is an interesting conversion here. Some estimates are that about 30% of the T3 levels in your blood are from peripheral conversion in the liver, not from your cells. And so that if you have low T3 levels in the blood, that might indicate poor liver conversion. Then the liver will remove the conjugated. It attaches sulfate and other glucuronic acid and whatnot to these metabolites, and then eliminates that in the bile. So that's sort of the life cycle there of thyroid. And that's the negative feedback. Now, what's going to be interesting is we can have different types of thyroid disorders. So just looking at the case of hypothyroidism, low thyroid output, we could have a problem in the gland itself, and that would be called primary hypothyroidism. When that happens, we'd have low levels of T4 and T3. And I'll talk about that here shortly. T4, T3 are not very water soluble, so they actually have to be carried in the blood bound to proteins. And so we talk about the binding proteins. There's actually a protein that the liver makes called thyroid binding globulin, TBG. Albumin also participates in this a bit, and the third one as well. But TBG, it binds up the T4, T3, carries it around the body. Only a little bit of that T4 is actually free in the blood, and we call that free T4. So free T4 is the amount of T4 not bound to TBG. And it's actually the only part of the thyroid that can be actually used in the cells. So what we're really interested in clinically is the free T4 levels, and that's what the typical assays are in the blood. But in the case of hypothyroidism, free T4 and free T3 are going to be low, but TSH will start to elevate because the brain will perceive low levels. It'll then put out more TRH and more TSH. So that's going to be the case in primary hypothyroidism. You can also have a problem, though, of where the anterior pituitary fails to put out TSH, and that can happen in a lot of different conditions. So, for example, it can happen as a result of a anterior pituitary adenoma. Most adenomas are hyperfunctioning. They would oversecrete TSH, and that would cause a hyperthyroidism. But you can get it where it also, in more advanced phases, the cells burn out. They become pushed out of the way by all the scar tissue and whatnot. And so then we're going to have low TSH, and that would cause secondary hypothyroidism when the TSH is low from the problem in the anterior pituitary. Thirdly, you can have a problem in the hypothalamus where we get decreased TRH, and that would cause tertiary hypothyroidism. So one of the things we do in the clinic is we measure TSH, we measure free T4, sometimes free T3. We'll talk about that here in a bit. And that will give us a way of sort of figuring out what the source of the hypothyroidism in this case is from. I'll just say currently in the medical literature, the secondary and tertiary hypothyroidism are now being called collectively as central hypothyroidism. So central meaning the central nervous system problems. Hypothalamic issues are very, very rare. Pituitary a little bit more common, but we usually lump those two together. Okay, so that's the HPT axis and the negative feedback of thyroid hormone. I wanted to say just a few more things about TSH, thyroid stimulating hormone. Again, this is secreted by the pituitary. It's a glycoprotein, so sugar protein. It was first discovered in 1916, and it has a half-life, as I mentioned, of about 1 hour. And its main role is to stimulate thyroid hormone release from the gland. Now, it's considered to be one of our most accurate measures of thyroid hormone levels, so this is currently our primary screening test for thyroid disorders, is the TSH. In hyperthyroidism, TSH is going to go down. In hypothyroidism, again, if it's a case of primary hypothyroidism, the TSH will go up. If it's a case of secondary or tertiary hypothyroidism, the TSH levels will go down. So they can be very useful for measuring your general thyroid status. Now we'll come back to that. There's a bit of controversy about, is TSH really the best measure of thyroid activity? It's of course not telling us what's happening inside the cells of your body, your skeletal muscle cells, adipose, where thyroid is being used. It's really only telling us about the thyroid usage in your hypothalamus. And some have argued that's maybe going to be a little different. The diodinases are a little bit different there than the rest of your tissues, and so you could actually be having adequate levels of thyroid activity in the hypothalamus, but then the rest of the body could be thyroid deficient. So that's where some of the controversy comes in. I'll come back to that when we talk about thyroid measurements. The actions of TSH, I've mentioned a few of them already, and that's primarily to stimulate the release of thyroid from the gland, but really it stimulates all the activities of the follicular cells. So it upregulates that sodium iodide symporter. It increases iodination of thyroglobulin, increases conjugation of the iodinated tyrosine residues, so brings them together into thyroglobulin, increases endocytosis of the iodinated thyroglobulin, increases the proteolysis of iodinated thyroglobulin from T4 to T3, and then increases secretion of T4 and T3 into the blood. But overall, it has an effect of causing hypertrophy and hyperplasia of the follicular cells. It also increases the vascularity of the gland, and the excess TSH could lead to goiter if it overgrows. Now that TSH receptor is again found on that outer surface of the follicular cells, as I pointed out. In Graves' disease, which is autoimmune hyperthyroidism, the immune system makes an antibody against the TSH receptor, and in this case it's actually stimulating. Now interestingly, in Hashimoto's, we don't usually measure it, but there are actually TSH receptor blocking antibodies. So those can block the receptor and further increase hypothyroidism. But typically we measure the thyroid stimulating antibodies in Graves' disease as a marker of Graves'. HCG, which is a pregnancy hormone, of course, from the placenta, shows some cross-reactivity to the TSH receptor, and so that can actually stimulate thyroid production. And that is what we think causes what's called gestational hyperthyroidism, when women get hyperthyroidism during pregnancy from the elevation of HCG. And that after pregnancy resolves because the HCG levels go down. Factors that increase TSH and thyroid hormone release would be obviously hypothyroidism, and that would be from the negative feedback, being cold, in cold environments, alpha adrenergic agonists, so anything to stimulate your sympathetic nervous system, specifically the alpha receptors in the central nervous system, and then having decreased glucocorticoids. So low cortisol and stress hormones will cause the thyroid to oversecrete, to secrete more. And that's an interesting sort of relationship there. We can think of the thyroid and the adrenals as kind of being on opposite ends of a balance, a fulcrum. And so one will compensate for the other if there's weakness, which can also be a problem if there's chronic weakness in one of the glands. The other gland has to basically overwork. There are factors that decrease TSH release, and that would be obviously hyperthyroidism, increased thyroid levels. Somatostatin, which you probably remember is a major inhibitory neuropeptide. We'll see it also inhibits insulin and glucagon. It inhibits growth hormone. In fact, its first name was growth hormone inhibiting factor, but it also decreases TSH. Dopamine and dopamine agonists like bromocriptine, they all will, of course, decrease prolactin, but they also decrease TSH. And increased glucocorticoids, cortisol, will downregulate TSH and thyroid. So again, that kind of balance act there. Now, interesting thing about TSH is it's released in a pulsatile manner, and it has a 24-hour diurnal rhythm. So if you look at this picture over here, this is TSH concentrations. This is plasma-free T3 levels showing the active thyroid. Notice that this is 9 a.m. Going into midnight, back to 9 a.m. Notice that the thyroid hormone, TSH, is actually highest starting around midnight, going into the morning, and it starts to drop off. And then in the morning hours, all the way up, especially up to the afternoon, so here's noon, but then getting to around 3 p.m., between noon and 3 p.m., it really bottoms out, and then it starts to come back up again. And notice the concentration. So here we have 2.4 milli international units per liter. Here we have down to 1.4. We have almost a whole 1 point difference in TSH in the same day. And so this is where I personally feel if we're measuring TSH values in patients as a marker of their thyroid activity, and we're doing that on a serial basis to kind of follow their thyroid, we should measure it at the same time of day. So if they come in one day at 9 in the morning, you get a measurement, and the next time maybe at 3 in the afternoon, we're going to have very different TSH values, even though it might be totally normal for them. And so basing your thyroid hormone dosages and whatnot on those readings might be incorrect if you are measuring at these opposite times. Currently, the guidelines are not suggesting that we measure thyroid at a specific time, like a lot of hormones, like testosterone and so forth, we need to measure in the morning hours. But currently it's basically any time. But I tend to take this into consideration with my patients I'm working over time with managing their thyroids. Again, notice that thyroid hormone is mostly secreted at night, and you see the same rise in T3. And that is very interesting in the sense that most people think of thyroid as kind of a stimulating. I mentioned that catabolic effect. We usually think of nighttime as your anabolic time, but thyroid is most active actually during those night hours. So this also has implications for thyroid replacement therapy. We're finding that our typical recommendations for patients who need to take thyroid hormone are to take it in the morning, usually an hour before your first meal, to allow it to properly absorb. And if you can't do an hour, then at least 30 minutes. But we're now finding another recommendation, which is to take it in the evening before bed. And that actually mimics your natural thyroid circadian rhythm. And I've actually experimented with that with patients and find that works actually pretty well for a lot of people. In fact, better than taking it in the morning in some cases. So that's important to know a little bit about the TSH circadian rhythm. Now I mentioned that once in the plasma, the thyroid hormones are not very water soluble. They're more lipid-like. In fact, that's why they can cross cell membranes fairly easily. There is a thyroid hormone transporter, but there's some ability of thyroid hormone to get straight across lipid membranes just by diffusion. About 99.9% of the T4 and T3 are actually bound to carrier proteins non-covalently, so they can easily dissociate, but they have to be carried by carrier proteins. And then that remainder, the 0.1%, is free thyroid hormone, and that can actually freely move into the tissues. We can think of the carrier proteins as creating a blood reservoir, so that as thyroid moves into the tissues, more dissociates from the carrier protein, so it's acting kind of as a buffer to the thyroid to allow it to kind of maintain a stable concentration in the blood. These binding globulins are all synthesized in the liver. So the liver, of course, makes just about all of our plasma proteins, and they're acting as I said, as a reservoir. So our main carrier proteins are thyroxine binding globulin, TBG, and that's going to be increased in pregnancy, high estrogen states, oral contraceptive use, and liver disease. And why that's significant is if you increase the TBG, you're going to have more thyroid being bound up to the carrier protein and less available to the tissues. So that's why high estrogen states often mimic hypothyroidism, because a lot of it is just because all that thyroid is being bound up to the binding globulin. I'll talk about the lab tests we do to measure thyroid function. We used to measure this one because this would be an important indicator. Now we can have direct assays of the free T4 and free T3, and so it's a little easier to predict how much active thyroid there is. Transthyretin is another thyroid thyroxine binding. It's actually called thyroxine binding prealbumin. It carries about 10 to 15% of your T4, T3, and then albumin would carry the rest. So again, it's the free thyroid hormones that are available. They're not bound to the tissues. And we actually call that the free or FT4 and free or FT3. So those would be our important indicators of thyroid availability. Now, in terms of clearance of thyroid, the half-life of T4, as I mentioned, is about a week. 80% is metabolized via deiodination via the D3 into reverse T3. And then the remainder is going to go through the liver, and then through glucuronidation or sulfation, it's going to be put into the bile and excreted that way. The plasma half-life of T3 is only a day, and reverse T3 is 0.2 days. So this is why we do see a lot of clinicians in the more functional circles actually measuring free T3 and reverse T3 as kind of markers of thyroid function. But the problem with that is that these are fluctuating wildly. So in a given day, depending on the hour, you might see a more than 50, 60, 70% variation in the free T levels, free T3 levels, and the reverse T3 levels. So they're not really a good marker of overall thyroid status. The one place we do find free T3 measurements are very helpful is in hyperthyroidism, because your TSH in primary hyperthyroidism is going to be very suppressed. And so measuring free T4 and free T3 is going to give us an estimate of how serious the hyperthyroidism is. Again, the free T3 is coming from, so when the free T4 gets into the cells, it's going to be converted via Diodinases to T3. Some of that leaks back out, and that's going to contribute to the plasma pool of the free T3. But some of it also comes from the liver, T4 to T3 conversion in the liver. That's also going to contribute to that. So that's why we can't really use the free T3 as a good marker for what we're really interested in is what's actually happening inside the cell, how much T3 is in there. And so there's not a direct correlation between those two. And that's why it's really hard to estimate just from T3 alone what's actually happening. Okay, so that's a little bit about thyroid hormone transport. So the real significant aspect of thyroid conversion has to do with the deiodinases, and these are the enzymes that are located in peripheral tissues. There are three types I mentioned: D1, D2, D3. D3 is also known as 5' deiodinase, so that's in the older literature you sometimes see that term used. These are selenoproteins. They use selenium as a cofactor, and different tissues have different concentrations and different levels of activity. We do know that people have genetic polymorphisms to the deiodinases, and that would theoretically impact their thyroid metabolism. But we don't typically screen for those, or we don't look for those. I think in the future that might be part of genetic testing to see if that might contribute to why a person might have hypothyroidism, is they're just not able, even though their blood levels of TSH and T4 and T3 are fine, are in the normal range and the euthyroid range, at the cellular level, they could be having issues because of the deiodinases. The deiodinases follow circadian rhythms and seasonal rhythms. So we do see that in the typical months when there'd be hibernation, the winter months, thyroid metabolism slows down, and that happens very commonly in hibernating mammals like bears and whatnot. But we think it happens in people too, that in the winter months, fall and winter, your deiodinase activity slows down, so you might get relative hypothyroidism. And then in the spring and summer, the levels go up, and so you get more normal thyroid activity. And so I do find with some patients we have to adjust their thyroid seasonally to kind of compensate for that if they're on thyroid replacement therapy. Zinc appears to upregulate D1 and D2 and decrease D3. So that's why we think zinc is another supporting nutrient along with selenium to support deiodinase activities. Now, some people do supplement. We'll look at the therapies for hypothyroidism, but some people supplement selenium, and selenium has to be taken in very small amounts because you can get selenium toxicity, but 200 micrograms, again, not milligrams, micrograms a day is a typical kind of selenium supplementation regimen. The selenium itself, we think, actually contributes to upregulating deiodinase activity. At least that's the theory. When researchers have looked at this, they found that actually most people get enough selenium, even with a fairly poor diet, to run the deiodinases. So the deiodinases really get enough selenium. But where selenium also plays a role is it is a part of glutathione. And glutathione, remember, is one of your major intracellular antioxidants. And so where we do see a role of selenium is in autoimmune thyroiditis. As the immune system destroys and attacks the thyroid gland, having more glutathione present in the cells will actually help protect those cells. And we do see that selenium can actually downregulate your markers, antibody markers for autoimmune hypothyroidism. So we'll talk about that in the Hashimoto's section, but that's where we think selenium plays a role, is in contributing to glutathione. But we do need a very small amount here for deiodinase activity. So the main effects of deiodinases are to either activate thyroid hormone, that's T4 to T3, and that's where the outer ring of T4 is deiodinated to produce T3. So that's showing in this, here's T4, here is T3, so we remove this iodine here. And so that's primarily the activity of D2 and D1. D2 is what's found in most of your peripheral tissues. D1 is found in the liver. So again, both can contribute to T3 levels. And then deiodinases can also inactivate T4, and that would be primarily D3, to some degree D1, but primarily D3, which converts T4 into reverse T3. And that is now inactive at the thyroid hormone receptor, so that's why we call that inactive. T3 can also be converted to T2, and I mentioned that's that form of thyroid that has just two iodine groups, and that basically is thought to also upregulate mitochondria and so forth. So that's where there could be a further role there. Again, a very important point is that intracellular concentrations of T3 can vary independently of the blood concentrations, and so that's why measuring free T3 may not really be telling you what's happening inside the cells, and why we currently don't see any of the guideline committees, except for the case of hyperthyroidism, as I mentioned, talking about using that really as a marker. Here's just a little bit more about where these are found. So D1 and D3 are found on the plasma membrane of cells, whereas D2 is found inside the cell in the endoplasmic reticulum. And again, the case of D2, we're creating T4 primarily. Most tissues have a lot of D2 and D3, whereas D1 kind of concentrates in the liver and to some degree kidney. Now, there are different inhibitors. I mentioned propylthiouracil inhibits thyroid peroxidase, but they can also inhibit deiodinases. So in particular, PTU can inhibit D1, and amiodarone, which of course is an iodinated antiarrhythmic medication, can also inhibit D1, potentially D2. So this can unfortunately inhibit thyroid. And so that's one of the medications we always look for with hypothyroid patients. Not very commonly used, but if a patient has atrial fibrillation or another cardiac arrhythmia, they might be on amiodarone for long-term treatment. And you can look at the things here that upregulated. I do want to say again with D3, the importance here is that glucocorticoids tend to upregulate D3. So we're going to convert more of our T4 into inactive reverse T3 in high glucocorticoid states. And that happens in the non-thyroidal illness syndrome, NTIS, I talked about. Okay, so this is a little overview of the different deiodinases. Finally, once the T4 is converted to T3 within the cells, the T3 then can actually bind to the thyroid hormone receptor, or a TR. The TRs are normally in the cytoplasm, and what they're going to do is they're going to then translocate to the nucleus with the bound thyroid hormone, and that is going to trigger gene expression. And those genes that will be expressed will lead to the production of proteins that are going to upregulate the metabolism of the cell. And we'll look at all in the next video, all the effects of thyroid on different tissues. But basically, they're going to increase the activities of mitochondria and all that action. The thyroid, T3, is going to bind with a lot more affinity than T4, which is why we say it's active thyroid. And it's going to bind to a hormone response element, HRE, in the DNA of the cell. And these HREs are actually retinoid X receptors, and they are derived from retinoic acid or vitamin A. So that's why we often also see vitamin A being recommended for patients who maybe have sluggish thyroids or thyroid activity, maybe to upregulate their metabolism. You of course have to be careful about vitamin A because it can bioaccumulate, causing vitamin A toxicity, but at least making sure that patients is consuming in their diet adequate levels of vitamin A to meet the nutritional needs. Interestingly, most of the vitamin A we get in the diet actually comes from beta carotene, which is really two vitamin A's stuck together, and then we have to cleave that to get vitamin A. Well, it turns out thyroid hormone is needed to cleave the beta carotene. So we can actually get a vitamin A deficiency state in hypothyroidism, which kind of worsens the problem. Then we get less vitamin A, we get less of these hormone response elements in the DNA, and we get less ability of the thyroid to bind to its receptor. Okay, so that's the role of vitamin A in the thyroid receptor. There are three isoforms of the thyroid hormone receptor, so the alpha-1, beta-1, beta-2, and they're expressed differently in different tissues. So cardiac and skeletal muscle express the thyroid receptor alpha-1. TR-alpha-2 is widely expressed, but it's actually unable to bind the hormone very effectively. TR-beta-1 is most expressed in the brain, liver, kidney, and then beta-2 is in the pituitary and hypothalamus. Certain gene mutations we know are associated with what's called thyroid hormone resistance. This is rare, but basically the hormone can't bind to its receptor because of one of these gene mutations. And that basically creates what we call peripheral thyroid resistance. And that's going to need a whole different approach than our typical thyroid disorders. Once activated, the receptor will again translocate into the nucleus. It's going to stimulate the production of genes, which will then be transcribed into proteins, regulating in the fetus growth and development, development of the nervous system, regulating heart rate, mitochondrial contractivity, regulating your GI peristalsis and renal water clearance, and modulating all your body's energy expenditure and metabolism, and we'll look at that in depth in the next video. So that is a summary of thyroid hormones, kind of again how they're synthesized, how they're transported in the blood, and then the thyroid hormone receptor. Again, in the next video we'll look at the actual effects of thyroid hormone in different tissues.